Hello, good evening. Welcome to February's My Macula and Me. My name is Kathy Elf. I'm the Chief Executive of the Macular Society, and it's just lovely to have so many people with us in the webinar room tonight. So a very warm welcome to you, and thank you very much indeed for joining us. Now, tonight we are going to be talking about a drug that is familiar to very many of us. It's called Eylea, the brand name of a drug known as aflibercept. Now, if you cast your mind back, you may remember that this was the second big sort of breakthrough drug in the treatment of wet AMD and similar conditions, diabetic macular edema, retinal vein occlusion, myopic maculopathy, a whole raft of drugs of conditions that have previously been untreatable until we got, first of all, Lucentis and then Eylea about 11 years ago. Now, the benefit of Eylea was that it was said to last longer in the eye than Lucentis did. And so people were able to go longer between treatments. And we know how burdensome it can be to have to drag yourself off to the eye clinic every 4 weeks for an injection. So there was a benefit to Eylea. Now, 11 years later, a new version of Eylea is about to be introduced in the UK. It is essentially not in just this, but essentially a bigger dose of Eylea. So what difference will that make? So this is the subject of tonight's My Macula and Me. And our guest tonight is a renowned retinal specialist based in the USA, Dr. Kenneth Fan. Now, Dr. Fan is a medical and surgical retina specialist who completed his training at the Bascom Palmer Eye Institute at the University of Miami, which I am told is effectively the Moorfields of the United States of America. It is the premier eye hospital in the United States. He's also trained in the field of inherited retinal diseases and gene therapy for rare eye conditions. And he now brings this expertise to his current post, which is in Houston, in Texas, at the Retinal Consultants of Texas. So, Dr. Fan, Kenneth, welcome, and thank you very much indeed for joining us this evening. It is a great pleasure to have you here, and we're very grateful indeed to you giving up your afternoon, I suppose it is, in Texas. But anyway, it's lovely to have you with us. Now, don't forget, Dr. Fan, Kenneth is going to talk to us about Eylea, this new dose. We have there will be time at the end of his talk for questions, which you can put into the chat if you would please, and we will as ever get to as many of them as we possibly can before the end of our hour. So questions in the chat. I'll just ask Abby to make sure that that is only it is because we've got two questions in the chat already. Okay, so Kenneth, welcome again, and I'm going to hand over to you to tell us about this new dosage of Eylea. Thank you very much indeed, Kenneth.
Yes, thank you so much, Kathy, for the warm introduction. I'm really, really happy to be here to share with you guys my experience with aflibercept 8 milligrams. Funny story. I was initially I did a little bit of training in inherited retinal diseases, and I had intended actually to spend some time at Moorfields, but never ended up doing so because of COVID. But that would have been a delightful opportunity. Let me just dive right into the presentation. Hopefully everybody can see my slides here. As Kathy had mentioned already, the topic I wanted to discuss today is newer therapies in macular degeneration, and in particular, aflibercept 8 milligrams, which we have had approved in the United States now for a couple of months and are using it quite a lot, actually. And I know that other parts of the world, ex-USA, including the UK, does not have access yet to aflibercept, but that is coming very soon. So, as Kathy mentioned, I work at Retina Consultants of Texas in Houston, Texas. It's a large group. You see the picture down here. We're kind of located in multiple cities, so we have a very large number of doctors, and it's great to work in such a wonderful group of very well-trained physicians and such great camaraderie. And I feel really lucky to be a part of this team. I do about 80% of my time is spent clinically. So in the clinic, seeing patients with macular degeneration, diabetes, for example, and also 20 to 30% of those patients have inherited retinal diseases. So we're talking diseases like Stargardt disease, Best disease, retinitis pigmentosa, and I'm sure that you guys are well familiar with these conditions. But the topic today, of course, is age-related macular degeneration, which we know that there's two forms of it. There's dry macular degeneration and wet macular degeneration, which I'll just say AMD from this point onward. Um, Historically, we've really only had treatments for wet AMD, and in the past year, kind of started um, treating patients with dry AMD with advanced geographic atrophy. So that has been a really amazing advancement in the past year. But today we wanted to talk about wet AMD, and we know that back in 2006, Lucentis was one of the first FDA-approved treatments for the treatment of neovascular or wet AMD. And ever since then, there's been so many different types of treatments and therapies that exist around the world, including Avastin, which is the off-label treatment, the generic treatment of wet AMD. Beovu, which some of you may know, was a very, very effective treatment actually when it first came onto the scene, but was kind of quickly swept away due to complications from inflammation and other adverse events. Eylea, the original Eylea or aflibercept 2 milligrams, which we know. Susvimo, if you're not familiar with this device, it is basically an implantation into the wall of the eye, the sclera of the eye, that is a refillable depot of ranibizumab or Lucentis, and actually has been very, very effective with the reduction of need for intravitreal injections. However, was recently actually taken off the market due to issues with that implantation device. So we are still kind of waiting to see how the company and also patients respond to that change of events. Vabysmo, which you guys may know, is also a newer medication, I would say in the past about 2 years. It is a bispecific antibody that targets both VEGF and Ang2, which people, we're actually still trying to figure out how effective the Ang2 component is of that. Cimerli and Biovis are very similar drugs, which are what we call biosimilars. They're kind of reformulations of Lucentis, and trying to make the drug more accessible and maybe less expensive to patients. And of course, here we've gotten now to Eylea HD, so 8 milligrams aflibercept, which is, I would say, the newest approval of a treatment for a neovascular or wet AMD that has kind of burst onto the scene the past couple of months. So this was approved in August of 2023. 8 milligrams, of course, is 4 times the dose of 2 milligrams, and has already been approved both for wet AMD as well as diabetic macular edema. So I kind of wanted to dive in a little bit to what the path and the journey of Eylea HD has been. So just a quick disclosure here: these slides were provided to me by Bayer, and I've kind of modified them just slightly to be a little more understandable, both to me and also the audience. But first, let me just say that we do know that it is 8 milligrams, and one of the first questions that I'm sure you guys have and I had was, well, does that mean it's 4 times the volume, or is it the same volume? But in fact, it is 0.07 milliliters of an injection, and the original 2 milligram injection is 0.05. So it's only about 40% more volume added to the injection itself. However, delivers 4 times the dose. One thing that I think is very, very interesting and important to understand about aflibercept 8 milligrams is that once you are done with the initiation phase of aflibercept 8 milligrams, so you get 1 injection for 3 months in a row, thereafter, the shortest interval between injections is 2 months. So I'm sure some patients, either know other people or maybe these patients that get monthly injections. But if you're getting aflibercept 8 milligrams or high-dose Eylea, it cannot be approved for injections more frequent than 8 weeks. And in fact, it's actually 7 weeks. There's a little bit of wiggle room, but you can't get the injections every 4 weeks. And that's simply because of the design of the clinical trial. So, the big rationale for testing 8 milligrams Eylea is because a higher molar dose, and this, I feel like this graphic shows it really well, is potentially lasts longer than in the eye and is able to extend patients out further between visits. So on the top here, you can see that we have the high molar dose, which is 8 milligrams, and then on the bottom is the lower molar dose, which is at 2 milligrams. And as time progresses, as the half-life of the drug, basically gets rid of the drug from the eye, you'll notice that there's more of the drug still left over at time X. And as time progresses, you'll see that, the idea is that more drug will still be available to the retina at a longer period of time. And so skipping over to the Candela study, which is the phase 2 study for aflibercept 8 milligrams, the study was basically designed in such a way that they were comparing aflibercept 2 to aflibercept 8, and there were about 50 patients per arm. And usually in these phase 2 studies, we're not necessarily looking at pure efficacy or superiority, but more of non-inferiority and safety. And so here you can see that the top in orange, which is the aflibercept 2 milligrams arm, received monthly injections for 3 months, and so did the 8 milligram arm as well. And then both were extended out several months and then received another injection. And at that point onward, it was decided that if the patients fulfilled a certain criteria, a loss of vision or some worsening of the actual anatomy of the eye, then the patients could be shortened by a month or so at a time. And the question was, were they going to look better or worse, and was there going to be any impact on the vision? So here you can see that there were 53 patients per arm at the end of the study, and actually a surprising percentage were female. So it was over 60% female, and the average age was 77 years old. Here, this slide I think is really compelling. You can see that this is a slide demonstrating the proportion of patients without fluid in the macula. So when we look at leakage or bleeding from wet AMD, we always look at fluid in the macula. And here on the left, you can see that this is after 4 months, and on the right, at week 44 or 11 months, almost a year here, basically, you can see that there's a difference between the 2 milligram arm and the 8 milligram arm at both time points, demonstrating that up to 43% of patients had no fluid in the macula after several doses, only 3 doses. And by the end of the study, 32% of patients did not have any fluid in the macula as compared to 15% in the 2 milligram arm. So here you can see that there's a statistically significant difference between the two arms in terms of how the anatomy looked. This is a great graph, yellow again with the 2 milligram arm and 8 milligrams being the blue graph here, showing that there's a difference also in the mean change in visual acuity. So you can see this is graded by letter. So when you're looking at the chart, when you're reading the letters on the chart, there's about a 3-letter difference between the 2 milligram arm and the 8 milligram arm over time, which is pretty significant, getting close to almost 1-line difference there. And if you think about what that realistically means for you on a day-to-day basis, that could be the difference between, let's say, 20/30 and 20/40 vision. I also find that this graph is super interesting. So on the left side, you have vision loss. So this is the proportion of patients with more than 5 letters lost, more than 10 letters lost, and 15 letters lost over the study period. And you can see in each time point, the 8 milligrams arm had a lower proportion of patients with vision loss. And on the right, you can see vision gain. Again, here with the greater than 15-letter gain, you have a much bigger difference between the 8 milligram arm and the 2 milligram arms, and same holds true for the greater than 10 letters gained. Here with the greater than 5 letters gained is about the same here, but I think that these large gains in vision are super relevant, especially with patients with very persistent disease and persistent fluid in wet AMD. Now that actually gave the green light to scientists to push for the Pulsar study, both Pulsar, which is wet AMD, and Photon, which is in diabetic macular edema. And the design of this study was slightly more complicated, but here you can see in orange still the 2 milligram arm. And then they had two separate arms of 8 milligrams, patients that would get it every 12 weeks, so Q12, that's what the Q12 means, and then every 16 weeks, which is the Q16 arm. And so they would compare these three arms side by side for about 2 years. And I don't want you to get bogged down by this graph, but basically this is just showing that the 2 milligram arm got, both arms received monthly loading doses, and then the 2 milligram arm just got every other month shots. And then the Q12 arm, or every 3 months, just got shots every 12 weeks with the option of either lowering the frequency between visits if they were not getting better, or increasing the interval between visits if they were improving. And same was true for the Q16 arm. So there was what they call a dose regimen modification criteria for patients, if they were to improve or to not improve, to tailor the treatment to those patients during the study period. And here you can see again the injections persisted all the way through year 2 with the availability of modifying the treatment based on how the patients responded. Now, you can see here that it was an even split between 3 arms, and about 1,000 patients were enrolled in this study. So that's typically a pretty big phase 3 trial. You can see that the average age here is a little bit lower than Candela, but about 74 years of age, and 54% female, so a little bit more even split there. So again, looking at the proportion of patients without fluid in the macula, you can see here that there's a difference between the blues and the orange here. And again, blues and orange. So this is both at week 16 and also the end of year 1, difference between those two groups. You can also see here, again, looking at the mean number of injections needed over the study period. I'm going to draw your attention here to the right side, where you can see that by the end of the study, patients who were getting aflibercept 8 milligrams in the 12-week or the 16-week arms only received about 8 or 9 injections, whereas the 2 milligram arm received 12 to 13 injections over the study period. So, actually there's a big difference here. Some patients were getting almost 5 fewer injections over the course of 96 weeks. So this diagram is a little bit hard to grasp right away, but basically, I kind of want to go over it with you. So basically, if you look at the left side here, those patients who were in the Q16 arm, 70% of those patients were getting shots at least 4 months in between their shots, or longer than that over the entire study period. And on the every 12-week arm, you can see that they were, and this includes also the 16-week arm, almost 80% of these patients were out to 3 months between shots and doing well. Because remember, if they were not doing well, they would be shortened to 8 weeks. And so you can see that, by the end of the study, almost 80% of patients were able to get out to 3 months. And here you have proportion of patients randomized to the 16-week arm who had a last intended interval of 16 weeks or even up to 20 weeks by the end of the study. So you can see here that 53% of patients were out to 20 weeks by the criteria of the study. So I think that that's actually really, we're pushing out to almost half of the year. So one injection every 5 months puts you at maybe 2 to 3 injections per year. One thing I think is super important to talk about is safety, right? Because this is not the same drug that we've been used to for the past 10 years. It's a different drug. However, there were no real big safety signals or concerns. One thing to to note is that, of course, it's a higher volume, but the study showed that there were no issues with intraocular pressure, which, as you guys may know, may lead to glaucoma. And so there were no incidences of glaucoma or persistently, yeah, elevated intraocular pressure from the medication. And so the last thing is, the study summary, and I will just draw your attention here that 78% of patients randomized to 8 milligram Eylea maintained an interval of greater than 12 weeks between shots by the end of the study. So I think that that is super, super awesome. And I do want to draw an asterisk here next to these results, because you have to remember that many of these patients, in fact, all of these patients, were newly diagnosed for wet macular degeneration. And I do have to fact check myself there. There may have been an inclusion criteria for patients who had not been treated with any sort of injections for several months, but many of these patients had not been getting any injections for up to 8 weeks. And so when we do end up treating these patients, many of them may not be in the same boat as a lot of, for example, the patients in my clinic. So when I switch my patients over and they have, let's say, very, very persistent disease, those patients may respond differently to high-dose Eylea than someone, for example, in the study. So there's a little bit of a caveat there. Now, briefly, I want to just say that there was a study also looking at diabetic macular edema, which was called the PHOTON study, designed in very similar way. You can see that there was a big difference between the number of injections required for the 8 milligram arm. You can just look here on the right side for 8 milligrams versus 2 milligrams. And again, the same graphs showing you that a huge proportion of patients were able to get out to, every 12 weeks or even every 16 weeks or longer between injections in those patients with diabetic macular edema. So I know I've been talking a lot here, but I want to show you one thing. And this is a patient that we have been seeing in clinic. And he had very persistent disease, as I'll show you in just a minute, very difficult to control, and had been getting monthly injections for a couple years, actually. And so this is just a snapshot from our clinic notes here. You can see that the patient was, just in the past year, got a shot in March, then April, then May, then June, July, August, September. Then he was a little lost to follow-up for 1 month. I think he didn't come for a couple of weeks due to some complication, and then he resumed his visits. And so here is, I'm sure you guys have seen these at your doctor's office, all the time. Every time you go in, you get one of these scans, which is called an optical coherence tomography. And basically what this is showing is some fluid or edema from wet macular degeneration. Generally speaking, as I like to describe to my patients, that I like to see these lines go flat across all the way. And I call this sort of like an X-ray of the retina. You're kind of getting a cross-sectional analysis. And the lines, I really like to see them nice and coherent, going all the way across and nice and flat. But here you can see there's evidence of a patient with fluid. And 1 month later, the patient comes in and still has fluid after an injection of Eylea 2 milligrams. And 1 month later, again, you can see that the patient still has fluid after multiple injections. And this is, after already several years of injections. Then the patient missed a couple of weeks of follow-up and comes in, I think, maybe about 7 or 8 weeks later. And you can see how much more of this black cystic fluid you can see on the scan. And this is just demonstrating worsening anatomical disease after missing their shots for a couple of weeks. So it was decided on this day to give high-dose Eylea. And you can see this is in November, that in December, there was such an amazing, robust response of flattening of the fluid that it actually got even better than where he was prior to having been lost to follow-up. So he was given yet another dose on this day, and still looks pretty good from a scan perspective, anatomically, doing very well. And so, what do I tell my patients when I talk to them about, maybe potentially switching them over to Eylea 8 milligrams? I do tell them that, of course, it's a newer medication, so there's things to consider in that regard, that it's 4 times the dose of Eylea 2 milligrams, that we haven't seen any major safety issues with the medication, that it's been pretty safe, and that a lot of clinical trials have demonstrated that you can achieve fewer injections over time, over the lifetime of a patient, or even just in a year without sacrificing visual acuity, which I think is really, really key there. And I do, also tell my patients that there are other newer therapies, as I mentioned at the beginning of the presentation, that are also effective for the treatment of wet macular degeneration. And Eylea 8 milligrams is one of those. And so, just kind of wrap up here, I just want to say that I do believe it's a great tool that, added to our toolbox for the treatment of wet AMD. But not every patient, would benefit from this necessarily, just because of the intricacies in it's the number of injections that you can get over time, and having to wait a certain time period between injections if you have very severe recalcitrant disease. I do believe the company is working on trying to change that restriction. But that being said, there's also patients with certain allergies, and let's say, do they just respond better to other medications? So there's flexibility there. I do typically consider Eylea high dose in patients with severe and persistent disease, to at least try it out and see how patients do, and see if we can get their intervals extended out a little bit further. And also those patients with very good disease, let's say they're, getting shots every 2 months, and they want to go 3 months. I think that is a very interesting and helpful use case scenario as well. And as I mentioned, a lot of other medications exist for the treatment of wet macular degeneration, and Eylea is just one of them. And there's a couple of restrictions based on the label, and I do believe the company is working on that. And so I'm excited for the future to see how we can continue treating patients with Eylea high dose, and hopefully we'll make some headway in getting it more available and accessible to all patients. Thanks so much. Really appreciate it.
No, thank you very much indeed. That was an absolutely fascinating explanation of it. We've come such a long way, haven't we, in the last
Yes.
14, 15 years. And 16-week intervals between injections is marvelous for patients, and actually for in the UK, a state-funded, free at the point of delivery, overstretched healthcare providing system of the NHS.
Yes.
It's transformative in many ways from those days when patients were coming every 4 weeks for injections. It really is
absolutely
amazing. Now we've got lots of questions. Please put your questions in the chat, and as I say, as ever, we will try to come to as many of them as we possibly can. I guess one thing that to clear up, this idea of the mole, it's a measurement, isn't it? It's a way of measuring the dosage, but
right.
it is how is this? How have they managed to get 4 times as much medicine into only 40% more volume? How
I mean, it's a reformulation of the solution of the drug. Molarity refers to basically a chemical concentration. So they were able to modify it in such a way to get more of the aflibercept into a smaller volume. And I think that is what has allowed them to be able to deliver such a high dose, because it becomes difficult and even controversial, let me just say, if you start injecting over, let's say, 0.1 cc's or 0.1 milliliters of drug into an eye, because we do have anti-complement agents that are 0.1, and patients do really well with that. But any more than that, then you're starting to kind of push the envelope. So if you just took the 2 milligram dose at 0.05 and you tried to push that to 8, well, you'd be putting in 0.2. So obviously that wouldn't be safe for patients, and I don't believe anybody would do that. But being able to do just 40% more with 8 milligrams is a really amazing achievement.
So just putting all that, if you just put 4 times as much of the existing dose into the eye, what would you do? You burst the eye. I mean, just put too much fluid in it. It would cause
You
problems
know,
in it.
even now with patients, if we give over, 0.1, let's say, sometimes, and our patients will know better than we do that sometimes they actually lose vision. The vision will get blurry, they may black out a little bit, and we have to wait for that vision to come back. So you have to be very wary putting too much volume in the eye during an injection.
It's a fixed capsule, isn't it? It's a
Right.
fixed system.
Correct.
It's
Correct.
a limited capacity. Okay, that's great. Let's get on to some of these questions. I think we've covered actually a couple of them. So we've talked about wet AMD. There are quite a few people on the call who are interested in whether it's other conditions as well. So we've certainly talked about DMO, what we call DMO, you call DME, diabetic macular edema. So it's going to be approved for that, isn't it?
It is approved for that. So there was the Pulsar and the Photon. They were kind of sister studies that were performed at the same time. So it was approved for both at the same time. Now, what it is not approved for is retinal vein occlusions, but that is actually being looked at right now. The phase 3 just closed enrollment. So we have all our patients enrolled, and we're kind of looking forward to when that will be approved for retinal vein occlusions, and I'm sure that it will be. So.
And then there are other conditions like myopic maculopathy. There are some other sort of dystrophies and other conditions, rarer conditions, which have neovascularization. Do you think they will come but a bit further down the line?
So myopic degeneration is a tricky subject. Not every medication is approved for the use of that. I don't know that Eylea high dose will be approved for that. We kind of have to wait and see, but I do hope that it will be approved for other indications that Eylea 2 milligrams is approved for. So only time will tell, but really hopeful, for the future.
A question here about Vabysmo. You mentioned Vabysmo as one of
Sure.
the newer drugs, faricimab, which also has extended the period between injections.
Right.
How do they compare? Has there been any comparison of those two drugs?
Yeah, a lot of people are looking at, first it was 2 milligrams of Eylea versus Vabysmo. Now it's sort of, well, what about Vabysmo versus high dose Eylea? And I think that it's a great research topic, and I think people are really looking at real world data comparing Vabysmo to high dose Eylea. I don't have a strict evidence-based answer for you. I know that some of my patients do respond pretty well to Vabysmo and have responded well to Vabysmo. I may maybe insinuate that perhaps Eylea high dose is a little more effective in my hands with my patients, but that may not be the case for everybody. The benefit of Vabysmo is that, like I said before, it targets the Ang2 receptor, which can be implicated in certain more inflammatory and diseases with a lot of leakage from the vessels, things like diabetes and vein occlusions and that kind of thing. And people are still trying to look at, is it truly effective, more effective in those cases than other drugs? But this is very sort of like hot off the press research topics that we're still looking for answers to.
And I guess the thing is that we're talking about different diseases, aren't we? But even with AMD, there are going to be different types of AMD. We're understanding more about that.
Correct. Yes, and that's a great point.
Range of alternatives for people to try is really important, isn't it? Some drugs don't work well for some people.
And I have patients like that. I'll switch them, for example, from Eylea, or let's say, Lucentis to Eylea, and they didn't do well with the Eylea, then I switch them to Vabysmo and they do really great, and vice versa. So
they're all slightly different. So the switching, several questions about switching. So I've been on having ordinary Eylea, started with Lucentis, changed to Eylea after several years. It's perfectly possible for patients on any existing drug to move to this new high dose Eylea if they and the clinician think that it's the right thing to do. There's no reason that somebody who's already been treated with one drug can't switch.
Right. Unfortunately, in the United States, we have a lot of regulatory and insurance, let's just call them hurdles for the selection of certain drugs for patients. And so actually we are still actually dealing with that a little bit, with certain payers not approving the treatment with high dose Eylea yet. We do have most government insurances approving that, but that could be one big roadblock. I'm not sure that that would be applicable in the United Kingdom, but aside from that, if the physician, agrees and the patient is interested, I would see no reason not to try it, except for the fact that perhaps patients may not be able to get out all the way to 2 months between shots, and that's something that I mentioned during the presentation.
Are there reasons? A lot of people with macular disease, several on the call tonight, are talking about they have coexisting glaucoma, for example, cataract, or sometimes glaucoma and cataract. Bad luck. Is there any reason why this would prevent them from taking high dose Eylea? Either of those
So
could be glaucoma
certainly,
or
yeah,
cataract.
certainly not cataracts. You have to be a little wary with glaucoma. I would just mention that to my provider and let them make sure that, as you get more and more injections, that the pressure is not going up. If it does, then you have to be careful. And they didn't note that in any of their studies. But one other thing, like I had mentioned before, is that if patients have a baseline higher pressure and they get an injection, sometimes they may black out from that. Like, the vision may go blurry after the injection. So if that is happening to you, then you definitely want to make sure you tell your doctor so that they can either take preemptive measures, maybe give you an eye drop to lower the pressure, or take a little fluid out, or maybe just stick with a lower volume of an injection.
Okay, that's really helpful. If people are switched, would they have to go back to having the 3 loading doses, is a question. So everybody who starts an anti-VEGF treatment has 3 loading doses a month apart, don't they? And then they go on to the sort of long-term regimen for that particular drug. Would everybody have to go back and have the 3 loading doses for this?
Right. Yeah. So currently, from the trial, that's how it was done, and that's how it's being sort of told to providers, that when you switch patients, you should give them 3 loading doses. In practice, obviously, that changes a little bit. You may have a hard time convincing someone who is getting shots every 3 months to come in monthly for 3 months. And so, it's a bit of a conversation between doctor and patient, I think, but by the book, yes, it is 3 loading doses, and then you extend them out.
Okay, that's really good. So a bigger dose of a drug which we know could have systemic effects, anti-VEGF, it inhibits the growth of blood vessels. And of course, you don't want blood vessels at the back of the eye in AMD, but you do need blood vessels rather
Right.
urgently everywhere else. So are there any systemic risks involved with a higher dose around the heart, or stroke risks, or anything like that? And any
Yes.
safety risks?
Luckily, in comparing 2 milligrams to 8 milligrams, no severe serious adverse events were noted. And that's over, 2 studies with 1,000 patients each. So I would say that I feel I feel no risk in injecting my patients who have, for example, cardiac disease or whatnot. I feel pretty safe giving that to them.
Okay, that's great. There's a question here from somebody in Scotland who wants to know how they persuade their consultant to increase the dose on the NHS in Scotland. You probably won't be able to answer that. I think it's probably the case that the regulator in Scotland would usually, in fact, sometimes be ahead of England in approving new drugs. So I doubt that you've got a problem. There's another one here about somebody who'd had lots of injections for wet macular degeneration, and they now have scarring to the eye. And there was no hope, no point in having any more injections. But is it could somebody who's ceased treatment return to treatment under Eylea? And a sort of an associated question, I suppose, is there any evidence of this high dose of Eylea actually being able to improve vision, not just not just
Right.
prevent the
So
progression?
what I tell a lot of my patients is, the anatomy is the anatomy, and if you have no fluid with 2 milligrams, the 8 milligrams is not going to improve your vision beyond what you already have if you're already at a satisfactory anatomical status. But if you have persistent fluid that you can't dry up with 2 milligrams or other medications, then perhaps getting the high dose Eylea can reduce that amount of fluid and improve the vision slightly. Now, in regards to the scar, I would say that probably, I agree with your provider that there may not be a whole lot of benefit to keep giving you injections if you have scarring under your macula. But if you have persistent, let's say, bleeding and fluid that is expanding, you don't want to lose the vision around that scar. And that would be probably the one of the rare instances where I may continue treating patients if I feel like they have some, just a little bit of peripheral vision next to the scar that they use a lot in their day-to-day. You wouldn't want that to get worse or go away. So, it's worth talking to your doctor about that.
Okay, thank you. There's a question here. I can see that quite a lot of eye care professionals asking some questions here. So quite technical questions. One is, and this is actually quite an interesting subject. Would we need, because we have this gatekeeper for NHS treatments called the National Institute for Health and Care Excellence, NICE, we call it, and normally they would have something, a health technology appraisal process for a new drug. Now, there isn't going to be one for this drug. And as I understand it, it's because the price hasn't changed. Is that right? Would you know about that? I think they're selling it at the same price. I don't think we need.
I will be honest with you. I don't think it is the same price in the United States.
Okay. Okay.
Yeah.
I think that's part of the reason there isn't going to be a new nice technology.
I could be wrong though. I don't I spend most of my time, seeing patients.
Yeah, okay.
Let's put it that way.
Somebody has asked for the link to the research study, but I don't know whether you can perhaps pop the name of the study into the chat so that people could see that. Kenneth, that would be really helpful.
Okay, I can only chat to hosts and panelists.
Okay, well, perhaps you could do that, and Abby perhaps will put it in.
Okay, yeah, so
for everybody to see.
So that would be right?
Absolutely fine. That would be great. So another question here around we've had approval, we've done that one. So Eylea is not yet available on the NHS, but it will be in possibly only a few weeks' time, because the process for approving it has been streamlined in this case. And so I think it will be available in the US pretty quickly. So this is not related specifically to Eylea high dose, but it's an important question from somebody who has wet AMD in both eyes, and I presume lives with her son who smokes. Is she at risk from his smoke? We know smoking is terribly bad for eyes.
Yeah, correct. Yes, I would say, without a whole lot of, research into the subject of secondhand smoking impact on wet AMD, but yes, we know that it is a huge risk, and it's probably not good for your disease.
No. I think the Surgeon General of the United States some years ago actually did go so far as to say that there was a causal link between cigarettes, not passive smoking necessarily, but smoking cigarettes and AMD. It is a very, very destructive condition, isn't it? So where do you think we go from after this? Is there a possibility of even longer lasting drugs, do you think, in the future?
I think so. The big topic of research now, and this is also relevant for the society, is gene therapy. There's a lot of research now in the area of gene therapy and delivering what we call anti-VEGF drugs into the retina so that the retina can produce that medication by itself. And so that is probably the frontier of medicine. And we're still talking about, well, I would say most of these studies are phase 1 and 2, but we do have one study that's in its later phases, Regenix Bio, looking at being able to do gene therapy and deliver that into the retina and produce anti-VEGF medication, over a longer period of time, and maybe even eliminate the need for injections in the future.
Just to go back to another aspect of this, the way of treatment and some of the conditions it might treat, macular hole. A couple of questions about macular hole. I don't think this is the right kind of treatment for macular hole. Am I wrong about it?
Yeah, that is so. That is correct. So you would not treat macular holes with injections or gene therapy. The best way would be through surgery, where you remove the vitreous fluid from the eye and maybe peel a little bit of scar tissue around the hole so that the hole can relax and flatten. And then you'll get a gas bubble in order to help close that hole.
So it's not relevant to macular hole treatment. Another question was about how you manage patients over these extended periods of time. Do you bring them back every month to have a look to see if there's fluid there, just in case it's not working? Or do you say, no, come back in 10, 12, 14, 16 weeks time?
Yeah, so I usually, let's say we're doing the initiation phase, I would see the patients monthly and then I slowly extend them out. And I've spoken to some experts in Europe about this, and some are okay, let's say going from 4 weeks to 6 weeks and extending 2 weeks at a time, and some are a little more conservative and do 1 week at a time.
Okay, so I think it's called treat and extend, isn't it? You keep
Yes, that's exactly what it is. Yep.
pushing it as much as you can.
Yep.
A couple of people have talked about eye drops. Is there a chance that this could convert to a drop, self-administered eye drop, rather than a
Yeah,
hospital?
so for obvious reasons, many people are interested in the efficacy of an anti-VEGF eye drop. Nothing has quite caught on yet, and it's also being looked at in the disease state of diabetes as well. But we have not gotten there yet, unfortunately. I think people are also looking at the oral treatments for these diseases as well, but so far, I would say the injections are by far the most effective.
We're funding a piece of research actually for somebody who's looking at the ability of a drug to penetrate the eye using
Yes.
nanoparticles and so on. And there is some glimmer, isn't there, of how
Right. Yes. No, there is. There is. And I think we're all very excited. But the trick is that, your cornea is all the way at the front and your retina is all the way at the back. So being able to, you know, get all the way back to the retina is a difficult task.
well, the eye is an incredibly clever structure, isn't it? That's
It sure
actually
is.
designed to stop foreign material from the front of the eye getting to the back.
Yes. No, exactly. Yeah.
Yeah. Somebody has designed that very, very cleverly. Another question here about slow release. So you mentioned the implant in the eye. This is what I think we've known here as the port delivery
Port
system,
delivery system, correct.
where the implant is topped up periodically and then it releases the drug slowly into the eye. Tell us a little bit about a bit more about that, if you would.
Yeah, so actually, it was approved a couple years back, and was very effective. It had the slow release of the ranibizumab drug, and even now we're seeing patients in long-term follow-up who had got the port delivery system who have very little evidence of disease and almost no need of rescue injections. But I will say, there was a safety concern which the company is addressing now, and they're hopeful that they can make necessary adjustments to the actual device or the way that the injections are refilled. The drug is refilled in the port in order to make it safe for patients.
Okay, that's great. Another drug that you mentioned was Avastin,
Yep.
which was originally a cancer drug, which was then repurposed for use in the eye, and it's still very commonly used in many parts of the world, occasionally
Yes.
in the UK, but very commonly used in the US still, I think.
Mhm.
How do those two compare, Avastin and Eylea high dose?
In my opinion, there's very little comparison. I think that the Avastin is it's an off-label use, and it comes from a compounding pharmacy, so someone has to compound it and fill it for you, at least here in the United States. And we've had actually a couple recalls of Avastin because of contamination and issues with the medication. So it's not exactly the safest medication, and it's also not the most effective medication. But I will say this: it is the most cost-effective medication, and the cheapest medication. And so, to be conscientious of healthcare burden as it pertains to cost burden, I think that has been a big a very heated debate among both patients and doctors alike, because there's a, of course, you have to decide if it were your eye, what would you do? But then you're talking about the overall healthcare system as well. So it's a very interesting question, and I think that still no one has the final answer, but and that is, you can see that that could be true because every provider has a different practice pattern and how much Avastin that they really use compared to, let's say, Lucentis or Eylea or Vabysmo.
It is a very difficult question, and in this country, it's been very useful Avastin, where NICE approval has mandated that vision has to fall below driving standards before you apply for treatment. I think that's honoured in the breach quite a lot now. But to begin with, it did mean that people could have treatment earlier, which was very helpful, I think. There's a desperate here. Please answer my question in letters. I have wet AMD and had the first dose of Eylea high dose. Now, this is probably a difficult question to answer, but in general terms, is it best to continue with Eylea HD or with the normal Eylea? So this person has started on Eylea high dose. That sounds like a good thing to me.
So without any other clinical information about that patient's eye, I would say, usually the provider will go through 3 treatments of the high dose and see how you look. And at that point, you can make a decision on whether you should go back to regular Eylea or continue with the high dose Eylea because of the timing of when you can get the medication.
Okay. Another question here, and I'm not sure totally, I'll try and understand this. Somebody has AMD in both eyes. The left eye is a new 9-month, right eye has been treated for nearly 9 years. Okay, this is an interesting point. Can both eyes be treated at with the same interval? I think the question is of time, or could there be differences that one eye needs to be treated monthly and the other eye every 3 months? Is that?
Yes, there is absolutely the possibility of different intervals between eyes. Yes, yeah.
Okay, so that's really interesting. I've never heard of that. That's absolutely amazing. Is there a link? Question here about lifestyle again. Is there a link between high blood pressure and wet AMD? There is a little evidence about it, I think, isn't there?
Yeah, there may be some insinuations, but the causal link is not as strong as, for example, the AREDS vitamins or sun exposure or smoking, as we had talked about. Yeah.
Okay, and in terms of looking at other conditions, we're dodging around a bit now. I want to get as many questions in the last 7 minutes.
Yeah.
And it's not approved, but if it were approved for retinal vein occlusion, would the intervals between injections still apply, as we've discussed with wet AMD patients?
It's hard to say, but I think probably yes, because I believe the design of the study is very similar. Yeah, and the FDA is going off of how the study was designed.
Okay, that's great. Somebody who has wet AMD in both eyes and has injections of Eylea at the same time. So in other words, bilateral treatment, both eyes injected on the same day. Would they still do that with the 8 milligram dose? Would that still be the practice, do you think?
Yeah. We do that as well here.
So no reason why not. A question here about scarring. We've talked about scarring on the eye, somebody whose treatment was stopped because their eye was scarred. Could you just talk us through that? What do we mean by that?
Yeah, the biggest question is, what is the visual potential of the eye? And let's say that there's severe scarring from chronic disease that went undetected or was untreated, for example. That scarring, if it has left you, only counting fingers, for example, then the benefit of putting monthly injections in your eye may not really be there. And the risks may outweigh the benefits because of the risk of introducing a needle to your eye every month, the risk of the pain and the discomfort of the injection or whatnot. And so if the visual potential is not there, oftentimes the risks outweigh the benefits. But on the flip side, if there is potential, let's say the scarring is very minimal, then it may still be worth it. But typically when we see scarring from macular degeneration, it tends to be pretty devastating.
And of course, the problem is it's very difficult. Well, we have no way now, do we, at the moment, of repairing that damage.
No,
The
we do
photoreceptors
not.
seeing
Yeah.
the eye are lost.
Early, yeah, correct. Early studies looking at maybe, this is sort of like a trigger word, but stem cells, very early studies looking at that, but no data yet.
Yeah, I mean, we're also funding a piece of work just coming to an end, I think, looking at we can create, well, I can't personally, but it is possible. People like you can create stem cells, photoreceptors from stem cells. The
Right,
problem
right. Yeah.
partly, I think, is getting them to, if you inject them into the eye, you introduce them into the eye, getting them to connect up with all the other systems in this very, very complicated organ of the retina so that they actually function once you put them.
Right. I would be wary of people saying that they can just harvest your stem cells and inject them into your eye, because that's a
Oh,
very
no.
dangerous thing to
Yes.
do. Yeah. The way that some companies are looking at it is creating a scaffolding of stem cells and placing it underneath the retina through surgery. So it's actually quite a very elegant and very delicate procedure.
Yes, actually, there have been some terrible cases, haven't there, of
Yes.
rogue stem cell
Yeah.
operators. So
Yeah.
it cannot be done at the moment. So if anybody tells you it can, you
Yes.
not believe them because it cannot
Yeah.
be done. Which brings me to another question about so-called magic treatments. Somebody here has mentioned a product I've never heard of called Sight Clear. But are there any magic treatments? I mean, are there any? Are there any?
To be honest, no. I don't believe so.
It's very sad, isn't it? But
Yes.
people can be quite easily conned, really,
Yes.
by some of the claims that are made for some uh, treatments that are not properly approved or tested. Um, tell me a little bit about what you think is what's your dream for the future? Where you mentioned gene therapy, stem cell
Yeah.
therapy. Do you
So
see lots of people want a cure, don't they? Will that ever happen, do you think? Could we ever get
for me, gene therapy is my hope for the future, not only because of macular degeneration, but also because of inherited retinal diseases. That's like that's a big part of my practice and my day to day, and I see a lot of patients with blinding conditions from an early ages, and so if gene therapy can work, and if it can be, the delivery of the gene can actually be found to be effective and non-inflammatory, that could be game changing for thousands of children around the world, hundreds of thousands of people with Stargardt disease, and um, you know eh, to be able to get to that point, I think would be truly amazing. Something that even 7 years ago, before Luxturna was approved by the FDA, had never been even imaginable. And I think now that we're sort of on the brink, it's not that far off. I would say maybe less than a decade away.
if some of these inherited conditions involve one or a handful of genes, a condition like
Sure.
AMD, dozens of genes, could it possibly translate into age-related macular degeneration gene therapy, do you think?
I think there's a possibility. The genomics are not quite there yet for AMD, but I assure you, there's a lot of money in there looking at how we can predict who will get macular degeneration and predict those patients with dry who will convert to wet. And even looking at geographic atrophy, what are some risk factors or genetic predictors for severe geographic atrophy in the way that it affects your eye and grows into the macula, for example. And so there's a lot of people looking at that, although we don't quite have the answer yet.
Okay, sadly, we have run out of time. There's one question: can you have these injections long term, or is there a time limit? And there isn't a time limit, is there? But there is. It just depends on the anatomical state of the eye and
Correct.
whether the treatment is working.
Correct.
I noticed somebody earlier said that she'd had 126 injections. So good for you, madam, and stick with it. I admire your tenacity with it. I really do. Kenneth, Fan, thank you so much indeed for joining us tonight. That's been an absolutely lovely talk. I'm so grateful to you. Thank you to everybody for joining us. Thank you for all your wonderful questions. We will be back on the the same time next month in March for our third session of the year, our third My Macula and Me. Thank you all for joining us. Kenneth, once again, thank you very much
The
indeed.
pleasure is mine. Thank you so much for having
Very
me.
much. Good. Have a good night, everybody. Good night.